Good afternoon, everyone. Are you able to hear me? Okay, thanks, Mpumi. So, Shada Adams here. So, the noon meeting is being hosted by the Division of Occupational Medicine. And we are fortunate to have Mpumi Zondo, who will be speaking. A topic will be on the prevalence and factors associated with power tool-related hand injuries of patients at Groote Schuur Hospital. Just a little bit of background on her. She holds an undergrad degree in biochemistry and human physiology and anatomy, and honors in bioinformatics, and she has recently completed her MSc in Epi and Biostats, all from the University of Cape Town. She's currently awaiting the grading of her thesis. Professionally, she's been working in the division of Epi and Biostats for the past 2 years as a research assistant and currently serving as a study coordinator for the last 1.5 years. In that role, she's been involved in the design, implementation, and analysis of the screen choice experiment. Additionally, for the past 8 months, she's been working as a data scientist at the South African Medical Research Council in the Burden of Disease Research Unit, where she's developing an R-Shiny app for the third comparative risk assessment for South Africa. So welcome, Mpumi. We look forward to your presentation.
Good morning, everyone, and thank you so much to you, Prof, for that amazing introduction. And thank you to everybody else for attending today. Can everybody hear me fine? Okay.
Yes.
Awesome. Thank you so much. So today I'll be sharing the results from my thesis as explained by Prof, which is a study I did at Groote Schuur Hospital on the prevalence and factors associated with power tool-related injuries at the Hand Clinic at Groote Schuur. Thank you to my supervisors as well as my collaborators. So to jump right in, hand injuries are a significant public health concern. They are among the most common causes. They're one of the most common cases that are seen in orthopedic clinics worldwide, including South Africa. In 2010, Pillay and Ramakgopa did a study at the Chris Hani Baragwanath Academic Hospital, where they looked at the spectrum of orthopedic injuries at the hospital. And they found that during their study period of 1 year, there were a total of 5,832 orthopedic surgeries performed. And of these surgeries, the trauma unit was the busiest with 2,480 cases, and this was followed closely by the hands unit, which had 2,027 patients. What is also important to note is that among the trauma cases, most of the trauma injuries were also to the hand. Thus, hand injuries were the leading injury site seen at orthopedic clinics and the leading injury site for hand injury operations. Numerous studies have identified the leading cause as the leading cause of injury to the hand. Another study that was conducted by Stewart et al., also at Chris Hani Baragwanath Academic Hospital, which looked at the causes of hospitalized traumatic occupational injuries, cited power tools as the leading cause of injury, accounting for 40% of all of the hospitalized hand injuries. These findings are not unique to South Africa, with a study in Kenya which looked at the causes of traumatic hand injuries also cited power tools as the leading cause, and power tools accounted for 26% of the injuries seen. These findings also align with similar studies that have been conducted globally in the US as well as Poland. Across the literature, it is well documented that the overwhelming majority of injuries associated with power tool use occur in adult men who are often manual laborers. Again, in the study that was conducted at Chris Hani Baragwanath Academic Hospital, which looked at traumatic orthopedic injuries, 89% of the injuries occurred in males. Similarly, a study done in South Korea, which also looked at hand injuries caused by power tools, reported that 97% of the cases occurred in men. Similar findings again have also been reported globally in Brazil and Australia. Although majority of these injuries occur in manual laborers, they do not necessarily only occur in occupational settings, but in domestic and home settings as well. Studies which have examined the most common location of injury have found that power tool injuries are not only a hazard in the workplace, but are also common in the home environment. In a South Korean study, it was found that 48% of the power tool injuries occurred in an occupational setting, with 52% occurring in a non-occupational setting. Similarly, an Australian study reported that 46% occurred in an occupational setting, with the remaining 54% in a non-occupational setting. Additionally, the COVID-19 pandemic and the stay-at-home orders had a further impact on injuries occurring in non-occupational and domestic settings. Several studies have reported that although during COVID-19, the absolute number of hand injuries that presented at emergency departments decreased, there was an overall increase in the proportion of hand injuries that occurred in a home setting, and this was particularly due to do-it-yourself activities. Currently in South Africa, there are no policies to protect consumers. However, policies do exist to protect workers who sustain accidental injuries at work. In 1993, the Department of Labor introduced the Compensation of Injuries and Diseases Act to establish a compensation fund that covers workers in the event of sustaining an injury during work. Any employee who sustains an injury at work that results in them being temporarily or permanently disabled or leads to their death is entitled to no-fault compensation. In the event of an injury, employees are entitled to compensation while they are incapacitated, as well as having their medical costs covered. Any person who employs more than one person is required by law to register their employees for COIDA and pay into the fund. The fund covers most employees. This includes full-time employees, casual employees, domestic employees, and any employees who work more than 20 hours in a month for a single employee. The only employees that are excluded from the Act are independent contractors and self-employed workers. In theory, all occupational-related hand injuries should be managed by the private healthcare sector. However, this is not the case, as Stewart et al., which was the study conducted at Chris Hani Baragwanath, found that 69% of the employees who sustained injury at work were eligible for COIDA. Despite the patient's eligibility, inefficiencies in the enforcement and administration of COIDA result in the gross underreporting of occupational injuries by employers and medical practitioners. Employers are often not compliant with COIDA and do not register their employees for compensation. Employers often fail to comply with COIDA due to defiance, lack of employee personal records, or disappearance of the company altogether. Furthermore, private medical practitioners are often reluctant to take on COIDA cases due to maladministration, and they are often unpaid and required to do extensive paperwork. As a result of the shortcomings in the enforcement and administration of the Act, the burden of managing work-related injuries is shifted onto our already overburdened healthcare system and the employees themselves. Despite the burden on the healthcare system and the considerable socioeconomic impact of hand injuries, there has been limited research conducted in South Africa. The two studies that have mainly quantified the burden of orthopedic hand injuries on the healthcare system and describe the etiology of acute traumatic hand injuries in occupational settings. And both these studies were done at the Chris Hani Baragwanath Academic Hospital. However, no studies have investigated traumatic hand injuries specifically caused by power tools in all settings. The aim of this study is to explore the nature, the context, the severity, and the determinants of hand injuries that are linked to power tool use. One of the study measures used to evaluate the severity of the hand injuries is the Modified Hand Injury Severity Score. What is the Modified Hand Injury Severity Score? This is a standardized scoring system designed to quantitatively assess and classify the severity of hand injuries, including injuries that are on the wrist and the forearm. It was developed in 2008 by Ursa and Baida et al. As an extension of the original hand injury severity score. The system evaluates the injury based on 4 anatomical components. Firstly, it looks at the integument component, so if there's any damage to the skin or nail bed. It looks at skeletal components, if there's any bone or ligament damage. It looks at motor components, if there's any tendon and muscle damage, as well as it scores the neurovascular components and any nerve or arterial damage. Each finger has a weighting factor based on the functional importance. So for example, if the same injury occurs in the thumb and the middle finger, the thumb will have a greater weighting than the little finger. Amputations are scored as all missing structures are damaged, and it also includes additional pathologies such as crush and open fracture wounds. The injury severity is then categorized into 4 grades. The injury can either be minor, moderate, severe, or major. The Moderate Hand Injury Severity Score is a highly valid and reliable tool for assessing injury severity. Studies have demonstrated that it correlates well with other functional outcome measures, such as the disability of the arm, hand, and shoulder score, which evaluates upper limb function. A higher MHIS score is associated with greater impairment, longer recovery time, and increased difficulty in performing daily activities. More importantly, the MHIS has strong prognostic utility. It helps clinicians predict the functional outcomes and long-term impact of hand injuries, guiding treatment decisions and rehabilitation strategies. Higher MHIS scores have been linked with longer hospital stays, greater need for surgical intervention, and extended rehabilitation periods. By using the MHIS, clinicians can better anticipate rehabilitation needs, advise patients on realistic recovery times, and facilitate appropriate occupational interventions to improve return to work outcomes. This is why the MHIS was chosen as the preferred measure of hand injury severity. On the screen here, you can see an example of the tool and the grading system that was used. A little bit about the methodology. So this study was conducted at a tertiary academic hospital in Cape Town, Groote Schuur. It was conducted between February and August 2024. It was conducted at the Outpatient Hand Clinic, which serves the City of Cape Town metropolitan area. It receives referrals from primary and secondary health facilities. The attending medical team of the hand clinic consists of consultants, fellows, and registrars specializing in orthopedics and plastics. The study enrolled 64 patients aged 18 and older who presented with acute traumatic hand injuries linked to power tool use. Patients who arrived more than 72 hours post-injury or sustained non-traumatic injuries, such as repetitive strain injuries, were excluded as they would skew the injury severity score. Participants then completed a specially designed questionnaire that was administered to them by their attending doctor. The questionnaire captured demographic data, employment details, safety-related characteristics, and injury specifics. Key variables included age, gender, dominant hand, employment status, employer responsibility for medical costs, and adherence to safety measures such as wearing gloves and using tools correctly. The MHIS was used to assess injury severity, which the scores categorized as minor, moderate, severe, or major based on the raw score. Statistical analysis was performed using R software utilizing multiple linear regression to examine risk factors associated with injury severity. Fisher's exact tests were used to assess the relationship between the type of tool and the injury location, as well as the type of tool used and the injury severity. On the results, the first results page, we can see that among the 64 patients who were enrolled into the study, majority of the patients were male. This was 91%, with a median age of 38 years old. Majority of the population also did not further their studies beyond grade 12. In the next slide, we can see that most of the patients were either full-time employees, casual employees, or they were unemployed. And alarmingly, most of them most of them were right-handed. Most of the full-time employees sustained injuries at work, with 70% of them being injured at work. However, only 55% of them reported that their employer had filed a COIDA claim. Casual workers were particularly vulnerable, with 100% of the casual employees sustaining work-related injuries, and 79% of them reported that their employer had not filed a COIDA claim. Many injured employees had to cover their own medical expenses, highlighting the significant gap in workplace protection and compensation mechanisms. Only 52% of the patients stated that their tool had safety features. Similarly, 50% reported that they had received some sort of formal training, be it trade school, an apprenticeship, or workplace training. And the other half reported not receiving any formal training in the type of tool that they were using. Majority also did not use PPE in the form of gloves as protection for their hands. Only one patient admitted to being under the influence of marijuana when operating their tool. The rest reported that they had not consumed any illicit substances within 12 hours of reporting the tool. Although there's inconsistency in the safety behaviors of the patients, most of them reported using the correct tool for the job. Finally, we can see that the most commonly reported tool was the angle grinder, accounting for close to half, 44% of all the injuries, and that is the instrument at the bottom. This is then followed by tape bandsaws, which are meat processing machines, and table saws. Most of the injuries occurred in a work setting, but there was still a significant proportion, close to 40%, that occurred in a domestic setting as well. The median injury score was 36, but there was a wide range in score, with the injury scores ranging from 15 to 55. Most of the injuries were either classified as minor or moderate, and although they were minor and moderate injuries, majority of them required surgical intervention, with 72% of the injuries resulting in some sort of surgical intervention. Also, alarmingly, close to half, 47% of the injuries occurred on the patient's dominant hand, which can have impact on their livelihood and their ability to perform work tasks. The leading types of injuries seen were fractures and tendon injuries, which often require, as seen in the previous results, often require surgical intervention as well as long-term follow-up and rehabilitation. This study found a significant association between the type of tool used and the location of the injury, with angle grinders most frequently causing injuries in a domestic setting. However, there was no significant association between the type of tool used and the injury severity. And this can also be seen in the diagram, showing that the tools, no matter the type, can cause a wide variety of injury severities. This study described the nature, context, severity, and determinants of hand injuries caused by power tools in a population of patients seen at the orthopedic hand clinic of Groote Schuur. These injuries typically occur in males of working age in both occupational and domestic settings. The most common tool implicated in such injuries was an angle grinder, and it was mainly used in domestic settings. The most common digits affected were the middle and the index finger, and most injuries were classified as either minor or moderate. The majority of hand injuries caused by power tools required some sort of surgical intervention. This study showed a diverse pattern in the types of injuries seen, with fractures and tendons emerging as the leading type of injury. The findings from this study align with those globally and locally, as typically power tools operate at powerful speeds, often resulting in high-impact injuries. These injuries occur mainly as a result of direct blade contact or machine kickback. Similarly, the variability in the nature of these injuries is also demonstrated in the distribution of the severity categories overall and when disaggregated by tool, with no single tool being associated with a severity category, indicating that tools, no matter the type, can cause a wide variety of injuries of varying severity. However, despite the variability seen in the pattern of injury, the findings in this study, along with others globally, show that these injuries often require specialist interventions and follow-ups, such as surgery and rehabilitation services. These findings are a cause for concern, as in South Africa, in general, there is a lack of orthopedic specialists. This issue is compounded by the maldistribution of specialists between the public and private healthcare sectors. In South Africa, the private healthcare sector only accounts for 14% of the population, yet 80 to 95% of the specialists in the country are employed by the private sector. Furthermore, in the public sector, there is only 0.36 orthopedic surgeons per 100,000 individuals in the population, and only 1.95 operating theaters per 100,000 individuals in the population, compared to the private sector, where there's 8.3 surgeons per 100,000 in the population and 12.1 operating theater beds per 100 in the population. This study showed that the nature of these injuries caused by power tools is associated with considerable morbidity and places a burden on the South African healthcare system, which is already chronically under-resourced. These findings are consistent with findings both globally and locally, as manual labor type jobs performed by power tools are usually done by men. Furthermore, in South Africa, young men are often required to find work immediately after high school or drop out early of high school to find work. These are also reflected in our results, where majority of the participants had not been able to further their education beyond matric. As they are poorly educated, their job prospects are often limited to manual labor type jobs. These findings illustrate the socioeconomic impact of these injuries, as patients often rely on their hands to generate income, and any temporary or permanent incapacitation could be potentially devastating for their current or future employment and livelihood. In this study, most of the injuries occurred in an occupational setting, with more than half of the occupational injuries occurring in either full-time or casual employees who worked more than 24 hours a month for the same employer. This study aligned with the findings of Stewart et al., who conducted the occupational hand injury study at Chris Hani, who found that more than half of the occupational injuries sustained were either by full-time or contract employees. And according to COIDA, employees who sustain injury during their course of their employment are entitled to compensation. Whilst this entitles them to seek care in the private sector, most seek care in the public sector, shifting the cost and liability onto the public healthcare facilities. These findings highlight the burden that these occupational injuries place on our healthcare system, even though in theory there is legislation to defray medical expenses and healthcare costs related to these types of injuries. The findings of this study are contrary to findings in South Korea and Australia, which reported an almost even distribution between the proportion of occupational and domestic injury, with slightly more injury occurring in domestic settings in these countries. However, South Africa is a developing country with a large informal manual labor market, and this could account for the increased proportion of occupational injuries that are seen in this country. Nonetheless, a considerable proportion, close to 40% of the injuries in this study, did occur in a domestic setting. Typically, prevention programs and legislation mostly concentrate on occupational injuries. However, these findings highlight that power tools are a risk in domestic settings as well, and prevention strategies and legislation should include lay consumers as well. In keeping with other studies, angle grinders and powered saws, excluding chainsaws, were the tools most frequently implicated in injury. An association was demonstrated between the tool implicated in injury and where the injury occurred. Similar reportings were found in Australia, where grinder injuries predominantly occurred in a domestic setting. These tools are often grinders are often preferred for their versatility, portability, and affordability, making them attractive to employers and recreational users alike. Furthermore, events such as the COVID-19 pandemic have contributed to the increase in the popularity of do-it-yourself activities, thus increasing the use of these cheaper, more versatile tools. These findings further corroborate that in South Africa, preventative and legislative efforts should be targeted at all users of power tools. A study in the US demonstrated that increased regulation in the manufacturing standards of power tools led to a decrease in the incidence of upper extremity injuries that were caused by powered saws. This study was unable to find an association between the overall severity score and the following risk factors hypothesized: age, use of gloves, prior training. Similarly, studies in Turkey also did not find a correlation between these factors and the patient's severity score. In South Africa, the study conducted at Chris Hani Baragwanath Academic Hospital, they were also unable to find an association between the overall severity score of a person and the use of gloves. There is no consensus in the literature, however, whether gloves protect against severity, and contrary findings have been reported in other studies where they have found an association between severity and the use of gloves. The overall severity score has been found to be better suited for predicting functional outcomes as opposed to predictors of severity. Some limitations that we faced in the study. The main limitation of the study was that it had a small sample size and missing data, resulting in the study being underpowered. But future studies should consider investigating these injuries in a larger sample from multiple centers using standardized tools to improve the power and generalizability of the findings. The linear regression model was also unable to explain the heterogeneity in the overall severity scores, and the data did not meet the assumptions of the model. Future studies should consider the use of more sophisticated, robust models, such as mixed effects models. In conclusion, this study highlights several critical findings about acute traumatic hand injuries caused by power tools in South Africa. The majority of these injuries occurred in the workplace, affecting economically active young men who often rely on their hands for their livelihood. Despite qualifying for compensation under the COIDA Act, many injured workers face challenges in accessing their entitled benefits, with underreporting and inefficiencies in the system shifting the burden onto the public healthcare sector. The study also revealed that angle grinders were the most common tool implicated in these injuries. Their accessibility, affordability, and versatility make them increasingly popular in both occupational and domestic settings. This trend was further amplified during the COVID-19 pandemic as more people engaged in do-it-yourself projects as they had more time at home. However, the widespread use of grinders comes with significant risks, as evidenced by the high proportion of injuries linked to this tool. These findings underscore the need for improved safety regulations, better enforcement of existing policies, and targeted educational campaigns to promote the safe use of power tools. By addressing these issues, we can reduce the incidence of these injuries, alleviate the burden on the healthcare system, and protect the livelihoods of those most at risk. Thank you.
There is one question, one answer. Hands clapping. Any questions? Please raise your hand. I can't see the names.
Maybe Mpumi can take off her presentation.
Mpumi, can you stop sharing?
Yes, I think I can do that. Hold on, grid view. How do I do this?
Go to share. Go to. Okay. Any questions? Please raise your hand. I'm going to ask one so long whilst people are still thinking about things. Mpumi, so we anticipated, because we were asked to do the study as a result of the increased number of cases linked to the sort of period of the pandemic, we anticipated higher rates. Was your sense that this was a lot lower than what we expected, the numbers that we got over the 3-4 month period?
Yes, definitely. And also the numbers included in the study. Well, firstly, it's because of the numbers included in the study, or the inclusion criteria of the study, because we had excluded injuries that occurred more than 72 hours afterwards. That also decreased the number of injuries reported in this study. So overall, we saw about 85, but in general, it was not as much as we had expected and or reported. So definitely it was not as we had expected or as was relayed to us. We did expect to see more than 100 cases.
The other questions, Mohammed?
Maybe Mpumi can put her
Yes, I
video on. Mike,
to video on.
so we can see you.
Oh, sorry, I thought it was on. Am I on now?
Let's see it. Am I doing this right, Mpumi?
Okay.
Okay, so while you are, my question relates, thank you very much. This was an excellent presentation and some very interesting findings. So I think one of the big aspects that we deal with in occupational health and occupational medicine is prevention. And you spoke to some recommendations with regards to prevention. Can you just elaborate a little on what you mean by additional safety regulations and how practically could this happen, especially for people in the domestic setting? And then I'll have a follow-up comment afterwards. Thanks.
Thank you so much, Prof, for that question. And it's such a cool question. So, and I kind of briefly alluded to it in my discussion. So one of the things that was done in the USA in around 2012, 2011, when they saw a huge increase in the number of power saws, is that they actually legislated across all domains. So whether you're buying the tool for domestic or employment purposes, sort of manufacturing standards. So manufacturing standards can look like all power tools that are manufactured have to come with an inbuilt safety guard that actually can't physically be moved. So that's one of the regulations that now exists in the States, in that all power saws that are manufactured don't have movable safety guards. So they've, as well as also they have done a lot of advertising, so similar to cigarettes, where they kind of, highlight on the box, the dangers of power tools and that people should caution themselves for their use. If you kind of go into Builder's Warehouse now as a lay consumer, you can just kind of pick up the box. There's not much on the box that would kind of deter you or warn you about the dangers. And there's also no manufacturing standards that currently exist in South Africa. So some machines that Bosch sells here, they actually cannot sell in the United States. So yeah, that's kind of what it could look like from our end.
Tyler, you have a question?
Yes, thanks, Mpumi, for a lovely presentation and for your study. I have a question about your findings. I know that most of those who sustained these hand injuries were the working population, but I think I saw primary school going children as well. Is that correct? And then were they operating these hand tools? I'm just quite shocked. So, or how did those injuries happen?
Oh, I'm so sorry. I probably did not. Thank you so much for your question. Also, I probably did not describe it properly. That was the educational level of the power tool operators. So some of them, if I go back to that slide, about 20% of them, so that's quite a large number of them, had not completed their education beyond primary school. The inclusion criteria was for people 18 and over.
Okay, thanks for clarifying. That makes sense then. Okay, so I then just also wanted to comment. I don't have more questions, but I just wanted to comment. You mentioned the disparity between the number of orthopedic surgeons available between the public and private sectors, and the caseload that they see. And then just to add to that, or compounded to that problem, at least for work-related injuries, is that many private sector doctors don't want to accept COVID cases because of the administration delays and other problems. So that's another compounding factor in this country. And then I also wanted to know whether you perhaps looked at, or otherwise it would be something interesting to look at, whether those that reported or that presented with work-related hand injuries actually reported to COID.
Yes, thank you so much for that comment. And it is a very, very true it's a very, very true phenomenon. We face almost a double-edged sword in the sense that employers don't want to report due to cost-saving measures. And then also private doctors are very, very reluctant because of all the bureaucracy that exists. And then I do have a slide. I probably glossed over it a lot faster than I should have. But yes, so for the people that qualified, what was really sad to see was that among the people who were casual employees, all of them were injured at work. So all 14 of them were injured at work, and none of their employers reported their injuries to COIDA. And only 40% of them, their employers were paying for their injuries. So the rest had to pay for themselves. Then in terms of the full-time employees, 70% of them were injured at work, and only 55%, so 11 of them were injured at work. Only 6 of the 11 reported that their boss had reported their injury to COIDA, and then the same 6 said that their boss was paying for their medical expenses. The rest said either they were not sure, didn't know what COIDA was, or that their bosses had not reported, and none of their medical expenses were being taken care of. So this really shows us the glaring gap, and it's something that was expressed to us by Prof. Solomons to Prof. Shahid and I when we first started this project, that a lot of these injuries should actually be at Palati, and they're not being reported, and the ones that are being reported, the Palati doctors do not want them. And that came out very clearly in our results. And it also came out clearly in the study at Chris Hani, which looked specifically at occupational hand injuries. And they also found that something like close to half, 50%, were actually qualifying for COIDA, and again was seen at Chris Hani. So it is a massive, massive issue.
Thanks, Mpumi. Thanks very much.
Viva, you can ask a question, unmute.
Good afternoon, everyone. Thank you, Mpumi, for the very nice presentation. I hope I got it correctly that you said most of the injuries were on the right hand, and most of the people who were injured were right hand dominant. I just wanted to ask on the factor of dexterity. Is it still a significant factor in the hand injuries? In my family, I have a lot of left-handed people, so they struggle a lot because most of the power tools are designed for right-handed people. So was it simply because they are truly right dominant, or because some of them are left-handed but are forced to use their right hands because that's the situation, therefore leading to most of the injuries?
Thank you so much, Tapiwa, for that question. So the reason we had asked for left or right-handed dexterity was then for us to be able to ascertain if you were injured on your dominant hand. And we found that 47% of people were injured on their dominant hand, which would obviously impact their livelihood, especially if you work with your hands. In terms of trying to understand how dexterity itself plays a role in terms of the configuration of tools and stuff, that was not something that I would say we were looking for or interested in. So I can't really speak to that in the sense of how the dexterity and the configuration of machines would contribute to injury. But that's definitely a very interesting question, because I myself am also somebody who was left-handed, that you're forced to use your right, and it comes with all these sorts of complications. But yeah, definitely something to look into. But yeah, our main interest was, what is your handedness, and did you then injure that dominant hand? Thank you. Sorry, I could not see.
Mpumi, there's another question. Question or is it Mohammed had a question.
Thank you, Mpumi. You're raising quite a few important issues. You also mentioned in your preventive, in your recommendations, issues around training and prevention. So conceivably, I can see this being possible in a workplace. Now, what do you do in terms of those folks who are using these tools in a domestic setting? What kind of suggestions or recommendations do you have with regard to those individuals? That's my one question. And then my second question is, you alluded to in your sort of limitations, perhaps your instruments that you use to assess, to score the severity may not have been appropriate or maybe sensitive enough. Are there any other kind of tools or instruments one can use to assess the kind of outcomes that you were investigating? Thanks.
Okay, so I'll start with the second question because I think it has a shorter answer. So yes, 100%, there are other tools. I also had mentioned that the hand injury severity score is better suited at predicting functional outcomes and not so much at being able to use factors that will be able to predict severity or be associated with factors that predict severity. Other instruments that do exist, there's something called the DASH score, which is the disability of arm, shoulder, and hand score. And that is a functional outcome score. That one is a lot more comprehensive because with the DASH score, it requires a score at baseline, and then it requires another follow-up score where you're actually able to assess the person's functional outcomes. So how they were at the beginning versus how they were at the end. So that could also then be another tool for consideration when considering severity or the impact that these tools have on people. Unfortunately, we were limited in the sense that we were a cross-sectional study, so we were unable to do any follow-ups. There's also another tool called the injury severity score. However, the injury severity score looks at the injury over the entire body. So because of that, if you're just focused on one anatomical region, your scores tend to be quite low and misrepresentative of the actual severity. But yes, definitely, if this were to be a longitudinal study, something like the DASH would have been a much more robust tool to use because it also includes follow-up and it looks at the actual functionality of the person's hand. And then to answer your first question around what would prevention look like in what would prevention look like in a domestic setting? In an occupational setting, we can enforce training. There's things like COIDA. So idealistically, Prof. Solomons had mentioned that, if there was a way to kind of regulate it, so kind of how you regulate alcohol and cigarettes, not anybody, he's of the staunch belief that not just anybody should be able to get into power tools at builders. You should be able to show some sort of capability or capacity in being able to use the tool before you're allowed to purchase the tool. Realistically, what I would say, which would be more realistically implementable, would be definitely looking at how they do cigarettes. So really just trying to raise awareness, look at the packaging, and on the actual packaging, demonstrate the risks of these tools and the type of injuries that they can cause, such that people will maybe think twice that, okay, these are the implications. Maybe let me try, or maybe let me be sure that I can use this tool or enlist some sort of professional help.
I just wanted to comment on that. Nowadays, if you buy an appliance like this, pressure cooker or something, you can register it on an app. So that's the other thing to think of, and it tells you how to use it as well. So I mean, perhaps, with the world going sort of very digital, that is something you can think of in terms of you have to sort of maybe go through the safety rules or the little induction before you can activate the tool. I don't know how much that would be in terms of expense, but I mean, that is where the world is going to. So that's maybe something else that everybody who buys a power tool actually has to read through that and be made aware of how to use it and what the risks are before you can actually even activate that.
Yeah, and I also thought of the sections where they actually sell the tools. They could have demonstration where people can be shown how to use the tools. So in these kind of places they have like people promoting their different products, so they could have someone there who's stationed there who actually shows people how to use the tools as well.
And I asked one more question before we didn't focus on the financial impact other than in a broad sense. It obviously has far-reaching financial impacts on the healthcare system in terms of the cost. I was wondering whether people in the hand clinic are actually reporting COVID cases, the doctors, because there is a requirement on a doctor to also report it. Do you know?
Just anecdotally, because when we were scoring the severity, I did have to go through the patient folders. And there weren't a lot of folders where I saw the compensation form. And when I was testing the actual questionnaire tool and asking people the questions myself, some people were like quite confused, what's COID and stuff like that. So yeah, from our end, in terms of Groote Schuur, I don't think it's something that the doctors do. Also, it's quite busy and it's a training hospital. So the registrars also change every 3 months. But yeah, it's not mandated by them. It's not something that I see them or I had saw them actively doing and stuff like that. I think the onus is really on the employee themselves to bring the form, say, doctor, can you fill this out? But of their own volition, it was not something that I saw frequently. And when I did the patient reviews.
Thank you. Any other questions? Anybody else? No? Okay, thank you very much, Mpumi. It was a very interesting presentation. I think stimulated a lot of discussion, and thanks for sharing it with us.
And we strongly encourage you to submit this to a journal for publication. Yes?
Yes, definitely. I think I just Prof and I submitted last week, so I ran away from Cape Town for a little bit, but I think I needed to find myself again. But most definitely, we are most definitely wanting to submit for a journal, and I'm very, very keen to submit to the journal as well as also feedback to the hospital. But yeah, definitely, it's in our pipeline to do.
Well done. Okay, thanks. Bye-bye, everyone. Bye.
Thank you, everyone, for your support. Good.